Imagine your hand won't move, but scans show nothing is physically wrong. Or one day your voice just disappears, but there's no lesion in your throat, there's nothing wrong with your vocal cords. Symptoms like paralysis, seizures, sensory loss, and no structural or clear identifiable disease to explain them. This is the world of functional neurological symptom disorder, formerly called conversion disorder. In this episode, I'm going to talk about what it really is, why it happens, how recent studies are changing our understanding of this condition, and most importantly, how we can talk about it with compassion, not stigma or skepticism. Historically, conversion disorder comes from the idea that emotional distress or conflict gets converted into physical symptoms. In modern classifications like the DSM-5 and in neurology, the preferred term is functional neurological disorder, or FND, or functional neurological symptom disorder. The symptoms of FND are real, involuntary, and cause genuine distress or disability. They are not feigned or all in someone's head. There is no structural damage like a tumor or a lesion that accounts for these symptoms. It's a disorder of how brain networks function, not of gross anatomy. Symptoms often mimic neurologic disease such as weakness, paralysis, tremors, non-epileptic seizures, sensory loss, feeling loss, speech changes, gait disturbances, and many more symptoms. Diagnosis is clinical. It's based on inconsistencies or rule-out features, like internal contradictions in exams, plus ruling out other neurological causes. It's as if part of the brain's messaging system are misrouting signals, writing the wrong address on a letter so the message never reaches the right mailbox. Patients don't produce symptoms on purpose. The brain's wiring is altered in its function, not its hardware. Over the past decade, neuroimaging like fMRI, diffusion MRI, connectivity analysis has revealed patterns of network dysfunction in FND across multiple systems, such as motor, limbic, attention, salience, and self-agency. For example, studies show altered functional connectivity, like how brain regions talk to each other. Some links are overreactive while others are underreactive. One study found microstructural white matter differences. They found this using diffusion MRI, and these were found between FND patients and healthy controls, suggesting there is a structural correlate, though it is subtle. Variability in BOLD signal, BOLD signal, variability in brain activity over time, is being explored as a potential biomarker for FND. But these are associations. We don't yet know cause versus effect. Do brain differences lead to symptoms, or do symptoms train brain networks to change? FND is best observed through a biopsychosocial lens. Biological predispositions combined with psychological factors like stress, trauma, emotional conflict, and social environment all play together. Many patients report a triggering event like physical injury, acute stress, or a medical illness preceding symptom onset. Research has looked at stress biomarkers like cytokines, microRNAs in FND and conversion disorder, exploring how chronic stress might biologically sensitize brain circuits. Psychological factors like impaired self-agency, which is reduced sense of control over one's actions, attentional biases, heightened somatic vigilance, catastrophizing, and dissociation are all implicated as well. We also have to look at the cultural and individual meaning, how a person interprets symptoms, beliefs about their illness also shape presentation and outcomes. Some years ago, long-term follow-up studies showed that many patients have persistent symptoms over years. For example, a 14-year study of functional limb weakness found 80% still had symptoms long-term. But more optimistically, intensive inpatient rehabilitation for motor FND has shown favorable long-term results in many patients. The variability of symptoms is a key aspect. New research shows that fluctuations in both motor and non-motor symptoms, like fatigue, cognition, mood, correlate with quality of life, especially mental health domains. Early diagnosis and multidisciplinary treatment are associated with the best outcomes. Because there's no one drug cure, treatment is nuanced and individualized. The gold standard is multidisciplinary care like neurologists, psychiatrists and psychologists, physical therapy, occupational therapy, speech therapy, sometimes rehabilitation settings like inpatient rehabilitation settings. Retraining and control therapy, which is also called REACT, is a newer behavioral therapy developed out of the University of Alabama. It's been used especially in functional seizures, which are non-epileptic seizures. A small randomized trial in pediatric functional seizures showed positive results. There's also a startup, React FND Health, which is now working to disseminate this therapy more widely, including through telehealth and telemedicine. Psychotherapy and psychotherapeutic approaches, including cognitive behavioral therapy or its variants, may help patients reinterpret their symptoms, reduce catastrophizing, and improve coping skills. Integrative psychotherapy approaches, combining somatic, psychodynamic, and cognitive elements are discussed in recent reviews regarding this topic. Physical rehabilitation and retraining, like physical therapy, can target retraining of movement, walking, their gait, their strength, often with motor retraining under distraction approaches. Often using motor retraining under distraction approaches, which is guiding the brain to relearn movements in non-threatening, like chill, non-symptom focused contexts. Basically, doing physical therapy and not focusing on physical therapy. Speech therapy for patients with functional speech or swallowing symptoms can be effective. And then there is symptom management and just supportive care, like addressing comorbid conditions like depression, anxiety, pain, and patient education, like helping patients understand that their symptoms are real, even if they are unexplained, and that treatments aim for regaining of function, not simply dismissal. Rehabilitation intensity and the setting is important because some studies suggest inpatient intensive rehab yields much better outcomes in motor FND. This is a core part because how we talk about it affects lives. Reject the fake, it's all psychological, malingering narrative. Emphasize that symptoms are involuntary, distressing, and disabling. Avoid language like just in your head or it's mental as a way to dismiss or minimize. Use person-first, non-judgmental language and talk directly to the person. Don't talk around them. Person living with FND rather than person with conversion disorder when possible. Acknowledge patients' suffering, the uncertainty, and the courage it takes to seek help when no one believes you. Normalize complexity and duality, nuance. It's okay to say, we don't fully understand this yet, while still validating and affirming that ongoing research is shedding light more on these conditions. Emphasize that brain and mind and environment all interact. Share stories and narratives with permission to help people feel less alone. Acknowledge how painful and isolating it can be to have invisible symptoms and to fight disbelief from clinicians, ER doctors, family, nurses, or even yourself. Empower with hope and direction. Treatment can help, especially earlier. Recovery might be partial or gradual, but function can improve. There is hope. Even when cure is uncertain, symptom management, coping skills, and adaptive strategies matter a lot. Encourage better training of health professionals in FND awareness. Avoid dismissive attitudes. Encourage better access to telehealth and training and interdisciplinary clinics. We are beginning to understand FND better. The science is evolving. Brain imaging is peeling back layers. fMRI. New therapies are emerging, but the core truth remains. Kindness, curiosity, and empathy matter as much as any protocol. To those listening who live with these symptoms, you are not imagining them. Your suffering matters. You deserve compassion, care, respect, and hope. Thanks for joining me, and I'll see you next time. Bye.